Hi, I'm Dr. Kenneth Chen, a nephrologist practicing at Kaiser Permanente in the East Bay in Northern California. I teach residents here in our internal medicine program, and sometimes they'll ask for a copy of my slides or will miss my talks, and so I decided to make my talks available. This will be the first in a series of talks that I'm going to make available on YouTube. That hopefully will benefit them and other medical students and residents alike. I'll be talking to you today about fluid management. This talk will help you understand both sodium and water disorders and the appropriate use of IV fluids and diuretics. I'm going to start with a fictional example of a patient in the hospital who's being kept around MPO and is being rounded on by a team of extraordinary fictional doctors, some of my favorite TV doctors and fictional doctors. I'd like for you to think about this example as we go along. As it turns out, there's actually a rationale behind the administration of maintenance IV fluids that I'll explain later in this talk. We have here a 50-year-old man who's admitted with pancreatitis, who's MPO. The sodium is normal at 140 with a normal potassium level of 4. The creatinine is also normal at 1.0 milligrams per deciliter. The weight is 70 kilograms and the blood pressure and pulse are normal. Each doctor wants to give a different IV fluid, so who's correct? A, Dr. Who wants to give normal saline at 70 mL per hour. B, Dr. Ross, who wants to give 1 liter normal saline bolus. C, Dr. Pepper, who wants to give D5.5 normal saline at 70 mL per hour. D, Dr. J, who wants to give D5W at 70 mL per hour. E, Dr. Gray, who wants to give lactated ringers at 70 mL per hour. And F, Dr. House, who wants to give D5.5 normal saline plus KCl at a concentration of 10 milliequivalents per liter at 70 mL per hour. As it turns out, Dr. House, who is my favorite fictional TV doctor, who's dual board certified in both infectious diseases and nephrology, is correct. I'll explain the analytical reasoning behind why we give maintenance fluids the way that we do. Sodium, along with chloride, is the effective osmolyte that holds water in the extracellular fluid space, and the sodium-potassium ATPase that's present on all cells maintains a sodium gradient between the intracellular and extracellular compartment, such that the majority of the sodium ions in our body are present in the extracellular compartment, while the majority of potassium ions in our body are kept intracellularly. Therefore, whenever you give saline to a patient, that volume of saline will stay in the extracellular fluid space until the kidneys excrete it to keep our extracellular fluid volume constant. But if you have someone with decreased GFR, any saline you give to the patient will be more likely to be retained and result in a volume overloaded state. Likewise, a patient with CKD who consumes a high sodium diet will become thirsty as a result and drink more water, which gets retained in the extracellular fluid space, leading to a volume overloaded state. This is why we often ask our CKD patients to restrict their sodium intake. This slide shows the volume of distribution of water in a typical individual. About 2/3 of our total body water is in the intracellular fluid space, while 1/3 of our total body water is in the extracellular fluid space. What keeps the fluid in our extracellular fluid space is primarily sodium, along with chloride to maintain electrolyte neutrality. If you look at the ECF space, 3/4 of the ECS space makes up the interstitial compartment of the body, while 1/4 of it consists of the intravascular compartment of the body. Colloids like albumin, blood, and sodium, along with chloride, help to maintain the intravascular volume. Sodium and chloride move freely between the intravascular interstitial compartments so that when you administer saline to an individual, it's going to eventually diffuse from the intravascular space into the interstitial space, while colloid, like IV albumin, will be more likely to stay within the intravascular space before eventually leaking into the interstitial space. So when you give 5% albumin to a patient, it's going to be more effective in maintaining or restoring the intravascular volume and blood pressure, at least initially when compared to IV saline, until it eventually diffuses into the interstitial compartment. So in a patient with heart failure or CKD, administration of volume like this can lead to pulmonary edema and peripheral edema. In terms of our daily fluid balance, we will usually drink about 1 to 2 liters of fluid a day and lose about 0.5 mils per kilo per hour in insensible losses of water from respirations, sweat, and stool. The remainder of the fluid we ingest is excreted by the kidneys in the form of urine. This gets back to the example I gave at the beginning of this talk. When you give maintenance IV fluids to a patient who is NPO, you want to make sure to give 0.5 mils per kilo per hour based on ideal body weight in the form of free water so that the patient is not becoming dehydrated while being kept NPO. If you don't give enough free water to a patient who's NPO, that patient will eventually become hypernatremic due to dehydration. I remember early on in my career, I was consulted on a patient with a sodium of 160 who was admitted to the surgical ICU after a Whipple procedure and was being kept NPO. For 3 days, he was given IV normal saline and nothing else until I saw him. The first thing he said was, "Doc, I'm so thirsty. Can I please have some water?" He had become hypernatremic because he was not being given any free water or hypotonic fluid while being kept NPO. So be sure to water your patients. Remember that sodium is the major extracellular cation and is responsible for most of the osmotic driving force that maintains the size of the ECF volume. So the ECF volume is determined by the total body sodium. So the more sodium a patient ingests or that you give in the form of saline to the patient, the more likely they are to become volume overloaded, depending on how fast you give it as well and whether the patient has heart failure, cirrhosis, or reduced renal function. Also remember that the ECF tonicity is determined by the cation and anion concentration in the ECF, which is mainly sodium and chloride. The tonicity, or the effective osmolality of the ECF, is what drives the movement of water across cellular membranes. So if you give a hypertonic fluid to a patient, water is going to move from the intracellular space to the extracellular space, while administration of a hypotonic fluid at too rapid a rate will lead to movement of water from the extracellular fluid space to the intracellular fluid space, which in severe cases can result in cerebral edema or even red cell lysis. This slide shows the normal physiological concentrations of the various electrolytes in our ECF and ICF fluid spaces. As you can see, most of our total body sodium is kept extracellularly, while most of our total body potassium levels are kept intracellularly. 0.9% saline or normal saline is isotonic, so when you give this fluid to a patient, there will be very little water movement across the cellular membranes, which is why we can give boluses of normal saline with impunity without leading to cerebral edema. The concentration of sodium in isotonic saline is 154 and not 140 to approximate the concentration of all of the cations normally present in our ECF volume, such that the total osmolality of normal saline approximates our serum osmolality. D5W is hypotonic and essentially free water. The dextrose serves as an osmotic agent to prevent rapid intracellular movement of water initially until it is rapidly metabolized. So be careful with the rate when administering D5W. Giving D5W at a rate greater than the rate of insensible losses will lead to hyponatremia. Lactated ringers is a more physiological type of fluid that provides some potassium and calcium and lactate, which serves as a buffer when it's converted to bicarbonate by the liver. Of course, this conversion of lactate to bicarbonate is going to be impaired in patients with liver failure. So how does our body regulate total body sodium or ECF volume? If you have a loss of fluid resulting in decreased ECF volume, arterial baroreceptors in the carotids will sense the decreased blood pressure, leading to increased sympathetic tone, which along with decreased renal arterial pressure and decreased sodium presenting to the macula densa, leads the JG apparatus to increased secretion of renin, which in turn leads to increased production of angiotensin I and angiotensin II, which is a potent vasoconstrictor which helps to maintain the blood pressure. Angiotensin II results in increased aldosterone secretion, which leads to sodium reabsorption in the distal nephron. Sodium and water is retained, leading to restoration of the ECF volume. The opposite occurs with an increase in total body sodium, where ultimately there is reduced aldosterone production and increased excretion of sodium and water to lower our ECF volume. Our sodium concentration is regulated primarily by our thirst mechanism and ADH, which is regulated by the posterior pituitary gland. As the plasma osmolality rises above normal, we will become increasingly thirsty to increase our water intake, while ADH secretion rises at the same time, which leads to free water retention by the kidneys to maintain our sodium level within a narrow range. Sodium disorders occur when there's an impairment in water handling or abnormal intake of water. Hypernatremia can occur, for example, when there's an excessive urinary loss of water in a patient with central DI who becomes obtunded and is unable to drink enough water to keep up with the urinary losses of water. Hyponatremia can occur, for example, when there is excessive or inappropriate ADH secretion. This graph shows how ADH secretion increases as our serum osmolality rises. At the same time as ADH concentrations rise, the urine becomes more concentrated due to water retention by the collecting duct under the influence of ADH. Additionally, we have baroreceptors in the carotid arteries and heart that will sense any fall in volume or blood pressure, leading to a steepening of the curve comparing the ADH concentration versus the plasma osmolality. So for any given rise in serum osmolality, there's a greater rise in ADH levels when patients are hypovolemic or hypotensive. In reset osmostat, the curve is essentially shifted to the left, as is shown in the solid blue line. For the kidney to regulate water excretion and to keep the tonicity of the ECF space constant, there must be an adequate GFR, adequate delivery of glomerular filtrate to the concentrating and diluting segments of the loop of Henle and distal nephron, intact tubular concentrating and diluting mechanisms, appropriate turning on and off of ADH, and ADH responsiveness of the kidney. A disturbance in any of these mechanisms or a failure of any of these mechanisms can lead to a sodium disorder. So to summarize, sodium disorders occur due to problems with water regulation. Hypernatremia will occur as a result of excessive loss of free water or inadequate intake of free water, and hyponatremia occurs as a result of the inability to excrete free water or excessive intake of free water. This slide summarizes the clinical signs and symptoms of sodium disorders in volume states. Water depletion or dehydration can be associated with increased thirst or dry mucous membranes, but an easier way would be to simply look at the serum sodium level. A water depleted or dehydrated patient is going to be hypernatremic and will need to be given more free water to correct the sodium level. Water excess is determined by a low sodium level. Volume depletion is associated with sunken eyeballs and poor skin turgor, low blood pressure, tachycardia, cool extremities, orthostatic hypotension, and a low fractional excretion of sodium. Hypovolemia is characterized by peripheral edema, hypertension, elevated BNP levels, and a high CVP or distended neck veins. An important point to remember here is that it's critical to try to determine the intravascular volume status in patients with hyponatremia to determine the etiology and appropriate treatment. The only way to determine the intravascular volume status is to assess the central veins and check for orthostatic hypotension. A hyponatremic patient who is orthostatic is likely to have a hypovolemic cause of hyponatremia, which would resolve with administration of IV saline. On the other hand, a hyponatremic patient who appears euvolemic on exam with no orthostatic hypotension and a normal BNP may actually have SIADH. Here are some clinical examples of various sodium and volume disorders. Some causes of water depletion or dehydration are diabetes insipidus, osmotic diarrhea, osmotic diuresis, or decreased PO intake. An example of water excess would be SIADH. Decreased DCF volume or hypovolemia can occur with vomiting or diuretic administration. Increased DCF volume or hypovolemia can be caused by heart failure, cirrhosis, or nephrotic syndrome. Some examples of where you can see decreased intravascular volume and thus potential causes of hyponatremia would be salt and water loss from a secretory diarrhea or diuresis, or third spacing of fluid from ascites or sepsis. Increased intravascular volume can be seen with heart failure or saline administration. So here's a short pop quiz. What's the definition of dehydration? It's simply water loss from the body and can be determined simply by looking at the serum sodium concentration. So if the sodium is up or the patient is hypernatremic, then they're dehydrated. So that's an easy way to diagnose dehydration. How's dehydration different from hypovolemia? Well, in dehydration, you have loss of free water from the body, whereas in hypovolemia, you have loss of both salt and water, leading to orthostatic hypotension or low blood pressure and tachycardia. How do you diagnose hypovolemia? Well, you can diagnose hypovolemia by simply checking orthostatics, or if you determine that the patient is hypotensive and tachycardic, those are other signs of hypovolemia. So in terms of principles of treatment, you want to know, first of all, how much volume to give or to diurese, and so you would want to estimate of the volume deficit, which is helpful if you know their previous weight prior to the insult, or you can go by vital signs and give them saline or volume until their blood pressure and pulse are stable and improved, or they're no longer orthostatic. If it's someone you're diuresing, it may be helpful to know what their prior weight was before they became volume overloaded, and that would essentially be the weight that you would aim for as you diurese them. So I'll often have a patient weigh themselves daily at home while diuresing and aim for about 1 to 2 kilos of weight loss a day until they reach their baseline weight. You need to look at what type of fluid to give them. Do you want to give some free water if they have a water deficit or are hypernatremic, or do you want to give volume in the form of salt water or saline? Do they need electrolytes that need to be repleted? For example, do they need some potassium? Or if they're hyponatremic, do they need hypertonic saline in order to bring up their sodium level acutely? So what happens when you give a liter of normal saline to a patient? It'll stay in the extracellular fluid space, and eventually 3/4 of the volume, or 750 mils, will move to the interstitium, while 250 mils stays in the intravascular space. What about 1 liter of D5W? Well, since water moves freely across the cellular membrane, the liter of fluid distributes evenly throughout the body, and 2/3 of the volume, or 700 mils approximately, will move intracellularly, while 300 mils stays in the ECF space. What if you give a liter of 5% albumin, which is in normal saline? Because this type of fluid contains both colloid and crystalloid, it's most effective in staying in the intravascular space and will be most effective in raising the blood pressure. However, eventually it will distribute throughout the ECF space, much as crystalloid, but just slower. So based on what I just said about colloids, you might expect that albumin would lead to better outcomes when compared to saline alone. As it turns out, there are 2 studies published in the New England Journal that refute this idea and showed that the probability of survival in the ICU setting was no better with IV albumin when compared to saline. It may be that some patients in the ICU are so sick that their prognosis is poor no matter what treatment you give them, and that would include colloids. The few instances where colloid would be recommended would be in patients with end-stage liver disease and possible hepatorenal syndrome, where you want to give them a fluid challenge, or as replacement fluid for therapeutic plasma exchange. There's a preference now to give more physiologic type of fluid for resuscitation in the ICU, such as lactated ringers or plasma-lyte, a fluid containing sodium, 140 milliequivalents, potassium, 5 milliequivalents, magnesium, 3 milliequivalents, chloride, 98 milliequivalents, acetate, 27 milliequivalents, and gluconate, 23 milliequivalents. This is mainly based on a study from JAMA showing that a chloride liberal strategy of fluid administration in the ICU led to more AKI and a greater need for renal replacement therapy when compared to a chloride restrictive strategy where a more physiologic fluid like plasma-lyte was given. So this slide shows the solid line, which is the chloride liberal arm versus the dotted line, which is the chloride restrictive arm, showed that in the chloride restricted arm, there was a lower risk of stage 2 or 3 AKI. And then from that same study here, you can see that patients who were given more chloride had a higher risk of needing renal replacement therapy. So when administering IV fluids, there are a few concepts to keep in mind. In order to replace a free water deficit in a patient who is hypernatremic, you need to know the volume of water in each type of fluid you're giving. You should be aware that there's no free water in normal saline. So giving normal saline to a hypernatremic patient will not lead to any improvement in sodium level, and in fact the sodium level would rise as the patient loses water through insensible losses. A liter of half normal saline or D5.5 normal saline will contain 50% water. So you could replete a water deficit of 500 mils by giving half a liter of half normal saline. A liter of D5W is 100% water. So alternatively, for that very same patient, you could give 500 mils of D5W to replace the 500 mil free water deficit. So why do we give water in the form of D5W and not sterile water? Because sterile water would move immediately into cells and will be more likely to cause cellular swelling, whereas the presence of dextrose in D5W acts as an osmotic agent to slow the movement of water into the cells, so the risk of cerebral edema or red cell lysis is lower. The advantages of lactated ringers is the lower risk of AKI when compared to chloride-rich solutions such as normal saline. And the lactate ion has an alkalinizing effect due to the simultaneous removal of lactate and hydrogen ions by the liver. Metabolism of lactate ions by the liver ultimately yields bicarbonate ions. The downside is you lose this alkalinizing effect of lactate in patients with liver failure or who are in shock with shock liver injury. Here in this slide, I show you how the water deficit equation is derived. I'm not going to go over that right now. You can take a look at this slide in your own time. But I do want to make an important point that when you're treating hypernatremic patients and replacing the water deficit based on the equation, you need to account for insensible losses of water too, and add that to the calculated water deficit to arrive at the total volume of water you need to give to correct the sodium. Remember I mentioned before that we have insensible losses of about 0.5 mils per kilo per hour of water based on ideal body weight. If you base it on actual body weight and the patient is morbidly obese, you may end up giving too much water if you base it on the actual body weight, since fat has a much lower water content than the rest of the body. It's not a big deal if you give someone kept MPO after midnight for procedure the next day, but if you have someone who's going to be MPO for longer than 12 to 24 hours, you ought to give some maintenance fluids. So getting back to my original question at the beginning of my talk, how would you write for maintenance fluids in that patient who is being kept MPO? You want to give enough free water to replace insensible losses, which is lost at a rate of 0.5 mils per kilo per hour. So for a 70 kilo man, you want to replace water at a rate of 35 mils per hour, assuming that's his ideal body weight. You also want to give some dextrose to prevent muscle wasting once glycogen stores are depleted. This is best given with D5.5 normal saline at a rate of 70 mils per hour. You could replace the water lost to insensible losses by giving D5W at a rate of 35 mils an hour, but then you wouldn't be giving enough dextrose to prevent the muscle wasting. Of course, this is a general rule of thumb. If you're not sure if you're giving enough free water, you can just check a sodium daily. If the sodium level is rising, then you need to increase the rate. If the sodium level is falling, you decrease the rate. You also need to give enough potassium to prevent hypokalemia. The kidneys are normally able to conserve potassium extremely well, but are not perfect. There's an obligatory loss of about 10 milliequivalents of potassium per day, so you also need to give at least 10 milliequivalents of potassium per day to prevent hypokalemia. In patients with advanced CKD or end-stage renal disease, you may want to leave out the potassium since these patients likely will not have this obligatory wasting of potassium given their low urinary output. So let's go over some clinical scenarios and see what kind of fluid we would give in various situations. In the first example, a patient with chest pain is being transferred to the ICU and is hypotensive with tachycardia. So in this patient, you'd give an isotonic fluid like lactated ringers or normal saline to bring up their blood pressure. In the second example, a 35-year-old patient is in septic shock. Here you would want to give a more physiologic fluid like lactated ringers, since we know that giving a chloride-rich fluid like normal saline will be more likely to lead to acute kidney injury. In the third example, a diabetic man with non-ketotic hyperosmolar coma who is hypotensive and tachycardic with a very high glucose level of 800 and an elevated sodium level of 168. In this example, you'd want to start off by giving an isotonic type of fluid like lactated ringers or normal saline initially until the vital signs are stable, and then switch to a hypotonic fluid to correct the hypernatremia. In this case, the patient has become hypotensive from an osmotic diuresis due to sustained hyperglycemia. Note that even if you're starting off with normal saline, you're going to start correcting the sodium level since the sodium concentration of 154 in normal saline is lower than this patient's current sodium level of 168. In the fourth example, an end-stage renal disease patient with a blood pressure that's mildly elevated at 140/90 with a pulse of 80, who's hyperglycemic with a very high glucose level of 800 and a normal sodium level of 140. What would you do for this patient? Well, this is kind of a trick question. An end-stage renal disease patient is not going to develop an osmotic diuresis from hyperglycemia. So in this hyperglycemic, borderline hypertensive end-stage renal disease patient with a normal sodium level, no fluid would be necessary. Here are more examples. An elderly patient who's comatose with a blood pressure of 110/80, sodium of 180, which is very elevated, and glucose of 100, which is normal. Here you'd want to give a hypotonic fluid very slowly, for example, half normal saline or D5W. In the second example, a patient with lung cancer, confusion and ataxia, with normal blood pressure and pulse, no JVD, no edema. The patient is hyponatremic with a sodium of 110, and the urine osmosis is inappropriately elevated at 680. So this patient has an inappropriately high urine osmolality in the setting of severe hyponatremia and appears euvolemic on exam, which would be consistent with SIADH. Certain small cell lung cancers can secrete ADH, leading to SIADH. This patient most likely has SIADH and is asymptomatic from hyponatremia, so hypertonic saline or 3% saline would be most appropriate in this case. In the third example, we have a patient with CKD4 and CHF admitted with pulmonary edema and nausea vomiting. The sodium is 150, which is elevated, with an elevated creatinine of 2. So this is another trick question. Because this patient is presenting with pulmonary edema, you would probably want to limit fluids in him or her. But this patient is also hypernatremic. So you could give D5W to correct the hypernatremia. If you give it at the right rate, you shouldn't contribute to the pulmonary edema since you're not giving any sodium. In the fourth example, we have a patient with cirrhosis who's orthostatic with a low sodium of 125, a fractional excretion of sodium less than 1%, and a urine osmosis that's inappropriately high at 280. In this example, this patient is orthostatic, so his or her intravascular volume is down. The low fractional excretion of sodium also supports this, though he or she certainly could have hepatorenal syndrome leading to a low fractional excretion of sodium. The urine osmolality is inappropriately high. So this is a case of hypovolemic hyponatremia, where the decreased intravascular volume, probably from third spacing of fluids in the form of ascites from cirrhosis, and increased venous portal pressures in the liver, is stimulating ADH release. The sodium level will be corrected by giving volume or normal saline to restore the intravascular volume and shut off the stimulus for ADH release. In the fifth example, an end-stage renal disease patient is being kept NPO for 48 hours. The weight's 75 kilos, sodium is 140, and the potassium is 4. So I bring this example up because sometimes clinicians are afraid to give any kind of fluid to dialysis patients for fear of volume overloading them. But even dialysis patients who are kept NPO for extended period of time need water to prevent dehydration. So here you could give D5.5 normal saline at 75 mL an hour. He or she doesn't need potassium in the fluid since there's no obligatory wasting of potassium in the urine, since the urine output is expected to be negligible. In terms of diuretics, the loop diuretics are the most potent, where about 25% of the filtered sodium load is excreted. The thiazide diuretics are much less potent, but can be given with loop diuretics for an additive effect, since they act in a different segment of the tubules. The potassium-sparing diuretics are the least potent and lead to very little diuresis when given. So I'm going to end with a slide on some of the pearls about furosemide that may be useful to you. An oral dose of furosemide is equivalent to twice the IV dose. Higher dose is generally required in patients with low GFR or nephrotic syndrome. In patients with low GFR, less of the furosemide is going to be filtered across the glomeruli, so the tubules are going to see less of the furosemide, so consequently you need to give a higher dose in order to achieve the same effect in someone when compared to someone with normal GFR. In someone with nephrotic syndrome, the furosemide is bound to the albumin that's lost in the urine, so the tubules see less of the furosemide that you give them, and so a higher dose is required to achieve the same effect as you would in someone without nephrotic syndrome. With normal GFR, a maximal response would be expected from giving 40 milligrams IV of furosemide, which should yield about a liter per hour of urine output. With low GFR, the maximal response will be from 120 to 160 milligrams IV of furosemide. For a drip, you want to give a 40 milligram IV bolus, followed by 10 milligrams per hour maintenance for GFR greater than 75 mils per minute, or 10 to 20 milligrams per hour for GFR of 25 to 75 mils per minute, or 20 to 40 milligrams per hour for GFR of less than 25 mils per minute. IV furosemide 40 milligrams is equal to 1 milligram of bumetanide, which is equal to 15 to 20 milligrams of torsemide. Our heart failure specialists prefer giving bumetanide if it's given orally as opposed to oral furosemide, given the better oral bioavailability of bumetanide. The absorption of furosemide may be less in someone with heart failure due to bowel edema. And finally, you can give metolazone, which is a thiazide diuretic, 30 minutes before a loop diuretic for a synergistic effect on diuresis. You want to give the metolazone 30 minutes in advance in order for it to take effect on the distal tubule before giving the loop diuretic. So this is the end of my talk. I hope you enjoyed it, and I hope that you find it useful. If you like the talk, please give me a thumbs up or a like, and subscribe because there'll be more talks coming. And if you have any comments, feel free to leave a comment or a question. I'd be happy to answer them. Thank you.